Good morning, everybody. I would like to thank you for coming to our seminar. I hope you're enjoying it, and I hope everybody leaves here with learning something new. I will talk to you about posterior dislocation and instability. Okay, the shoulder has the greatest range of motion in the body. It's got motion in all three planes, but unfortunately it sacrifices stability for mobility. So what's instability? A biomechanical dysfunction. It's a failure of static and dynamic stabilizers, and it ranges from mild subluxation to traumatic dislocation. So static stabilizers, we've got the ligamentum structures, the labrum and the capsule, and the bony configuration of the glenoid and the humeral head. For dynamic stabilizers, the rotator cuff and the scapular muscles. So for the glenoid, the greater the retroversion, and depending on the shape, we might be prone to instability, and also the greater retroversion of humeral head, we can have prone to posterior instability. The inferior glenohumeral ligament plays a significant role in the extremes of internal humeral rotation. The posterior capsule, as you heard before, is thin, and the ligamental structures are less clearly defined. So especially above the equator. The rotator interval also plays an important role in the humerus in neutral rotation, and incising the rotator interval can cause posterior translation up to 50% and inferior translation up to 100%. The subscapularis muscle provides the greatest resistance to posterior subluxation of the humerus. So what's the etiology? We've got traumatic and atraumatic posterior instability. The atraumatic instability, usually there's no history of true dislocations, but you have a history of a minor trauma or repetitive microtrauma, and it can be associated with capsular laxity. Traumatic instability usually is a dislocation sustained during a significant injury. For atraumatic posterior instability, it's usually individual with loose joints. You can have subluxations or positive apprehension signs in forward flexion and internal rotation. You can also have a posterior pain or clicking and functional impairment also in flexion internal rotation. Frank dislocations, they are rare, but they could happen with minimum violence, often induced by the patient. So unidirectional posterior shoulder instability is much less common than anterior instability. It should be strongly suspected in those category of athletes with posterior shoulder pain under clicking. And weightlifters, racket sport athletes, rugby players, golfers, swimmers are at higher risk. They might have lax shoulders that might be an advantage for the sport, but they make them more prone to instability, and they can also have repetitive trauma that will lead in chronic instability. So lesions usually found might be a posterior Bankart lesion or a Kim's lesion. That's an incomplete and concealed avulsion of the posterior inferior labrum. Posterior inferior Bankart lesion, and also you can see a Kim's lesion. So for physical examination, we do what we usually do: range of motion, strength, general ligamentous laxity, tenderness, a special test for posterior stress test, jerk test, load and shift test, or Kim test. Now, traumatic posterior dislocation. Well, first described by Hippocrates, and then Sir Astley Cooper described the posterior dislocation in a patient with a seizure, and in 1855, McLaughlin described a series of 37 patients with posterior instability before the advent of radiology. It's really rare. 2 to 5% of all shoulder dislocations may be difficult to diagnose, and it's often missed on 50% of standard AP views. It's caused usually by high energy trauma, but it can be caused by epileptic seizures or electric shock. It's caused by a force on the flexed, adducted, and internal rotated arm, or in the cases of seizures or electrocution, because the internal rotators are twice as powerful, then a sudden contraction could cause the humeral head to dislocate posteriorly. Associated lesions is a reverse Bankart lesion, a reverse Hill-Sachs lesion. It could have a lesser tuberosity fracture or a posterior Hangler lesion. Now, a posterior dislocated patient attempt to adduct or externally rotate can be painful. Usually you can't externally rotate beyond the neutral position. So it might resemble like a frozen shoulder, and we don't usually have any vascular or nerve injuries. So lock posterior dislocation is easily missed. This is a patient of ours. He had posterior dislocation for 1.5 months before it was found out. Another patient with 10 months of posterior dislocation, and another patient from 1 month. So usually we do our X-rays, AP, and axillary views if it's possible. CT scan and 3D reconstruction are very useful on MRI and MRI arthrogram. For X-rays, look for radiographic signs like the light bulb sign or the through line sign. CT scan, as we said before, and 3D reconstruction. So what do we do with a posterior dislocation? Well, it depends usually on the function of the functional status of the patient, how much time has elapsed since the injury, and the diagnosis. If we have a glenoid defect, the size of the Hill-Sachs lesion, and the condition of the articular surface. Few evidence-based protocols out there. Soft tissue injuries, a posterior Bankart lesion, you will do a capsular labor repair, and if it's a loose joint without a labor injury, you might need to do a capsular shift. For bone defects, you can do a transfer of the subscapularis tendon in the Hill-Sachs, the reverse Hill-Sachs lesion, so a McLaughlin procedure, transfer of the lesser tuberosity, rotational osteotomy of the humerus, maybe allograft, photograph reconstruction, or shoulder arthroplasty. You can do open procedures or arthroscopic procedures. So arthroscopy has a low morbidity. You can easily access the entire joint and then treat associated pathology, and it's easier to revise. How do we make it easy? Because it's supposed to be difficult. Not really. The only thing you really need to do is reverse the portals. So with the arthroscope in the anterior superior portal, you evaluate the posterior labrum and the glenoid, or you can also evaluate the reverse Hill-Sachs lesion. This is a video, but it's not playing. Okay. So this is from anterior superior portal, and we're evaluating. So I think this has moved a bit forward. Can I go back? Okay, thank you. So we do usually what we said before: mobilize the posterior labrum by using a shave or a vapor. Place 2 to 3 double-loaded anchors starting from the lower part, and if it's hyperlax, then you might do application. So now we are looking from the anterior superior portal. From the posterior portal, using the switch and stick or a probe, you can define this posterior Bankart lesion, mobilize it, put an anchor in, and then with a suture pass the labrum and fix it and tie down. You've seen this before, I think so. So for reverse Hill-Sachs lesions, if it's a big lesion, we can do a McLaughlin procedure. So we usually abrade the reverse Hill-Sachs lesion and put 1 or 2 double-loaded anchors and do a tenodesis of the subscapularis. This is a patient that had the ones we saw before with a posterior, locked posterior dislocation. This is 3 months postoperatively, and there's another patient with 3 months postoperatively. So take-home message is posterior dislocation is a very rare injury. Be suspicious if there's no external rotation, even if the other movements are possible, and look for radiographic signs. If any doubt, ask for a CT. Arthroscopic treatment is a reasonable treatment, even for locked posterior dislocations, if close reduction is possible with good results. Can easily address associated lesions, and just remember to reverse the portals. Thank you.